Good morning and welcome to our very first BurnCast. This is BurnCast focusing on Suprathel. My name is Cindy and I work for Trauma and Burn Surgery. But the real stars of this podcast today are going to be Anne and Liz. Anne, why don't you tell us a little bit about yourself and what we're going to be talking about today?
I'm one of the trauma burn nurse practitioners. Today, our hot topic is a new dressing that we're using and implementing in our burn patients. It's called Suprathel. Suprathel, Suprathel. It is a very thin, almost paper-like dressing that we're using. It's non-biologic, so it's replacing something that people may recall if they've used before called xenograft, which was actually a pig skin product. This is a non-biologic, so it doesn't come from any other animal or other skin parts. It's a very elasticy kind of membrane that is meant to replace your epithelium on a burn injury. And we layer it on top of our burned area, and it kind of absorbs into the skin. You can see a photo here of somebody's hand, which the first photo is the looks like a deep partial thickness burn injury to the hand. The second photo, that white, is the Suprathel. And then the third photo is once the Suprathel kind of melts into the skin a little bit. And that's what it looks like after it absorbs slightly, and then it dries up. And then that fourth photo is towards the end when the skin underneath of it has healed, and the Suprathel is kind of removed off a little bit, but some of it has absorbed as well.
Hey, Anne, how long? So these pictures are really interesting with like it kind of looks like you're just putting paper all over the burn, and then later it looks like it just kind of absorbs and disappears. How long does that take? So say you put it on like day one, what day does it like completely absorb?
It actually, in the operating room, it's a refrigerated product, so you can actually kind of start to feel it under your gloves start to get a little bit soft even when you first start with it. And I can't give you an exact day of when it goes from looking like a sheet of paper to looking like it's absorbed, because what we usually do is we leave it in place for 3 to 5 days and don't take it down until 5 days. And by the time we take it down on 5 days, it looks like that. So I don't know exactly when it happens, but probably within the first like day or two.
And in general, the company tells us that the healing time is about, 7 to 14 days or so.
Wow. So you said is it only placed in the operating room, or is it something that could be placed in the ER or at the bedside in the PICU? Like where is this placed?
Now we've started and we're mostly placing it in the operating room, but it is something that we could start using in like a bedside PICU setting or potentially the emergency department. The longer we have it and the more we use it, the more we'll know as to kind of how we would use it, but it will be applied by the burn team. So it's not something that the PICU team or the emergency department team needs to feel that they need to start understanding how to apply it. We'll make sure that we take care of that for you.
Okay, so this isn't something that our nurses need to like learn how to put on. This is just something that we as nurses just need to know like what's in place. And so are there any things that nursing or anybody taking care of a patient with Suprathel need to worry about? Like sometimes if a patient has Silvadene on them, we know that like kids with sulfur allergies can't have it. Sometimes we watch the white count. Is there anything that we need to like look out for if a patient has Suprathel?
Nothing in particular, really. There aren't any major allergy interactions. If there is one part of it is, it's a lactic acid substrate of some sorts, but that's I don't think I've ever heard of anyone who has an allergy to that particularly. But it's really kind of a pretty benign thing that's generally tolerated. So I don't think that there's any major contraindications to it. We wouldn't use it on like a full thickness burn necessarily, but as long as the burn is amenable to the Suprathel, then kids can definitely have it.
So what types of burns would you use Suprathel on? Like what makes you think like you see a burn and you're like, oh, this is a great candidate for Suprathel?
Well, I think for now, really, because we're putting it on in the OR, it would be a kid that we're admitting with a bigger burn anyway. So I think, again, this is a pretty new product. We've just started using it within the last couple of months. So those bigger burns, kids that have a TBSA of 6%, 7%, again, we can get coverage of the torso, the arms, kind of in one fell swoop. So the bigger burns for now, but as Anne said, I mean, we are totally committed to using this more frequently once we get a little more comfortable with it.
And where did we hear about this product? Like, why Suprathel and why now? Like, is it brand new for everyone, or is it brand new in kids, or is it just brand new to us?
Well, in the burn world, we've been using xenograft for quite some time. Xenograft, as you remember, is a porcine derivative. It's pig skin. And similar to Suprathel, it's something that you put on in the OR, you set it, you kind of forget it. The skin heals underneath over time. Months ago, we heard that they were discontinuing xenograft. So reaching out to the company, we asked, what's the replacement? And they said, gosh, there really isn't any. So the burn community started talking, and this has really become kind of the number one product that's emerged. And folks across the street at the hospital center are burn surgeons across the street using lots of it, really, really like it. And so we decided that we would kind of join the club.
Okay, that's interesting. So we are using it on bigger burns, like burns that we're admitting in, placing dressings basically in the OR. Does it have to be like deep partial thickness, or can it be superficial partial thickness? I feel like Anne earlier said that you're not using it on full thickness burns. So is there a certain depth the burn has to be? And is there a certain type, like, could you not use it on contact, but you could use it on a scald? Would you ever use it on like a pretty bad, like road rash burn? Like what types of burns would we be using it on?
Of the injury isn't necessarily what would qualify or disqualify someone in terms of if it's a contact burn versus a spill or scald burn. What we're looking for is usually the partial thickness burn. So superficial to deep partial thickness, it's oftentimes burns have a bit of a range in between the two. So there may be areas that are superficial, areas that are deep partial, and you're covering all of them. We rarely see that beautiful burn that is only one type of partial thickness. So in the partial thickness burns, I think are generally our main candidate, which are most of the burns that we see, especially most of our spill scald burns.
Totally. As you guys know, our burn population is less than 2, spill scald, anywhere from 1 to 10%. That's kind of the bread and butter of what we do. So.
Okay, so the Suprathel is placed in the OR. It's placed by our burn team. Generally partial thickness burns and generally the bigger ones, and it's new. So once you put this like paper-like substance on the burn and it slowly absorbs, you've got to put something over it, right? You can't just tell a kid, okay, in 3 to 5 days, this should be absorbed in your skin, but don't touch it. So like, what do you do to keep it in place? And like, how does it want to absorb into the dressing? Like what makes it like absorb into the skin and not what you're putting over it?
Layers that we put over it are it's called interface. It's kind of like a fine mesh, and then on top of that we may put Xeroform, which is something that a lot of people know of, which is that Vaseline bismuth impregnated gauze, and that really kind of helps separate anything above it, any dry gauze, because we have to put a Curlex wrap and a dry dressing and allow for any absorption of any drainage that you have from sticking. So the interface really is a layer that kind of protects the Suprathel and doesn't make whatever dressing you're putting on top of it stick. So we'll do the interface layer, which is just this kind of mesh of sorts. And then on top of that, a bulky dressing that can absorb any drainage that comes. And then we wrap it with Curlex or cling, depending on the area of the body. And then we try and do some form of compression. Compression is really important because it helps improve the healing, and it allows the Suprathel to really stick on. So you may see Coban on your patients. If it's coming from the OR, that's often a brown Coban. Occasionally we get some fun colors for you, or an ACE wrap or something like that to really keep it in place. And that's also another layer that allows you to know that that dressing is really kind of there and not going to just slide off as soon as your kid wakes up and starts moving around.
Oh, well, that's a lot more complicated than I think it sounded at the beginning. Because at first it's like, we have this amazing dressing. It goes from paper to gel and it kind of just sticks in and it like replaces the skin. But so now we have Suprathel, which is this amazing dressing. But then you're putting another dressing called Interface. Can you spell that?
Like the letter N?
Oh, okay.
Yeah, with a dash and then TERFACE.
Okay, so
It
Interface.
sounds more complicated than it is, I promise. It
Okay.
really you put down, you put a little interface on, and then you kind of add like a dressing and wrap it up. I promise.
1, 2, 3.
So I feel like one question that I've seen our nurses have before, which I feel is like 100% valid, because we've never put Coban on our burn kids. This is very new to us. And Coban is not even at the bedside for our nurses right now, because there have been there's been problems in the past with possibly not being able to assess pulses or bad things happening when Coban's been placed. So recently, with our addition of burn providers from the Washington Hospital Center, we've had a couple kids show up with Coban even before Suprathel. That kind of freaked everybody out, because it's like, whoa, where is their Coban on this patient? And how are we going to check pulses, or how are we going to check cap refills? So if you have an extremity that's all wrapped up, including the fingers, how are our nurses supposed to assess the pulses or cap refill, like in a hand, or how do they document that they aren't able to check it? So what do they do in those circumstances?
When Coban is something that is getting a little bit more use in the inpatient world, but we use it all the time outpatient.
Oh yeah.
So in burn clinic, we put kids in Mepilex, and in order to know that they can go home and be their crazy 2-year-old selves and keep their dressing on and come back, we wrap them up with some Coban to protect it. And so it is something that we have a lot of experience with. It's just something that often when they're in the hospital, if they're already staying with us, we don't necessarily put Coban on it, because we know we're going to be changing the dressings and we're going to have them with us for a while. But the Coban offers a little bit of a compression. The question about the cap fill is an important one. Certainly, we're generally pretty careful about when we're wrapping up fingers to wrap them in a certain way to make sure that we kind of position the hand and then we wrap it. And then you can check if it's an entire arm that continues, we make sure that we wrap it distal to peripheral. We make sure that we're wrapping it so that it's not just stopping at the wrist and cutting off circulation. But if you have a line where the Coban stops on an arm or an extremity, for example, you can make sure that you're not getting extreme swelling proximal to it. And then in terms of documenting, I'm not 100% sure how that would go, because I haven't been a nurse documenter in a while. So you may have to tell me about that one, Cindy.
So what you're saying, it sounds like you're always like leave a finger out at least, so you can check cap refill.
And again, in terms of more of a neurovascular exam, just again, cap refill, colors again, and just talked about looking for swelling, excess swelling. So
pain, like the Suprathel shouldn't hurt. Once the burn is covered, usually patients don't have pain. If all of a sudden they're complaining of terrible pain in their hand, that may be something that we need to know about, because it's an acute change. It shouldn't be a very focal kind of pain.
Okay. That makes sense. I just know that there's been a couple people who've brought it to my attention that they're like, oh, we haven't seen Coban inpatient before. How are we going to check pulses? And, even like even just having like one finger out, if you can't check a radial pulse, but you can check the perfusion of that finger, like that's way better than not. But knowing that like people are being mindful of like leaving a couple fingers and just making sure that like that assessment like can be done. So I think that answers my question.
Definitely. And if there's a question, call us, we can certainly pop by.
Right. I feel like these questions only happen like on the weekends at 2 a.m.
Oh.
So I want to make sure that we like answer all those questions before it happens. Like Monday through Friday, 8 to 4, we have like tons of people that are great and that want to answer questions. But sometimes like all of the resources aren't there. So I want people to be able to know what to do if they have a question.
Sure.
Surgeon on call, and our residents have access to them, and they're more than welcome, especially if it's, and sometimes it's our hospital center guys and they just pop over from next door to take a look at something. So we don't want anyone to be concerned about something and not let us know. We'd rather be informed about it. So it's a really good question. And that's why I think it's also going to be important for us to have a good sign off when the patient comes back from the operating room so that we all are on the same page. And when the injury allows, we will try and leave out an ability to check when possible so that you don't have to kind of worry about it. But sometimes it's not feasible depending on what the injury is.
Perfect. Okay.
You may see these Washington Hospital Center burn attendings rounding on the weekends too. So again, they're a great resource. They're using tons and tons of this. I think they're the best resource for all of us.
Okay, good to know. Okay, so let's do a quick case scenario. So we have a kiddo, they're 2 years old. They came in on Friday and they went to the OR on Saturday. So we don't have our nurse practitioners in house, but we have our friends from the Washington Hospital Center that took the kid to the OR. They have a 18% burn, so they were in the PICU. The PICU did the fluid worksheet amazingly. Everything's perfect. They go to the OR, and the anesthesiologist also knows how to do the sheet, so they're keeping the fluids perfectly. And the kid comes back, and they put Suprathel on the kid. So we have an 18% burn with Suprathel. And we know that it was placed in the OR, and we know that there's on top of the Suprathel is the interface, and then the Xeroform, and then Curlex, right? So they're all wrapped up, and maybe a little Coban depending on where the burn was, but that's what we see. And then they get them back to the PICU. Everything's going great. And the mom rushes in. She's so happy to see her kid. She has a big cup of Coca-Cola and spills it all over the bed, the kid, the dressing. So now the entire dressing is saturated in Coca-Cola. What does the bedside nurse do after she has the mother forcibly removed from the room? Just kidding. Oh, and the team's already left.
Yes. I think you start by trying to kind of like you stop the burn, you stop the soak, right? So try and get like the gown off, get whatever you can, soak up as much as you can, and then call the burn team.
Okay, and if the burn team just happens to be like in the OR putting another dressing on another burn, like what does the nurse do? So say the dressings are completely saturated and it's going to be like an hour or two before somebody can come to the bedside. Do they just wait and let the burn sit with that Coke on it, or any fluid? So say like the kid threw up, or the kid needed like went to the bathroom or something. Somehow all the dressings are nasty and gross, and it's going to be like an hour or two before somebody can come and assess. What do they do?
Generally, when we use this product, there's going to be a lot of layers in between. Oh, I don't know if you guys can hear that. My cell phone just started ringing. I think there are going to be a lot of layers in between the Suprathel and what you actually could get soaked. And if there's an ACE wrap or a co-band, it also is going to add another layer of protection. So in this instance, if you cannot get in contact with a burn team and you cannot talk to them, they are not able to give you some sort of advice, I would leave the dressing how it is and wait until you can get their assessment. It's going to depend on the burn, the location, the person who wrapped it, and how they know how it's wrapped and what's underneath of their co-band. Adds a nice kind of semi water.
It's like a little water resistant. Yeah. It's pretty durable stuff.
Okay.
You might actually be more protected because the co-band kind of wick away some of the water. So maybe we got some of the coke to the bed instead of the dressing. So I would err on the side of leaving it there until someone can come assess how damaged it truly is.
I think Anne has a really good point, because if a kid had something like Mepilex AG on with a wrap and maybe a Tubifast shirt, if you spilled something on that, it's like going to saturate everything. But yeah, this is lots of layers. And again, I think you'll get an answer at some point, but I think leaving well enough alone for the meantime is good advice.
And, I think that this really turns into a really good topic that we could do in a future BurnCast of all of the different dressings that we do and what to do if they get soiled at the bedside. Because I think that like planning for worst case scenario is really would be really helpful. And sometimes when like these dressings come and they look beautiful, and then life happens and they get dirty, or it's been a couple days and there's a lot of exudate coming from it and it smells bad, and everybody's like, ooh, we don't know if we should touch it, we don't know if we should take it down ourselves, we don't know, like, how long do you let somebody wait in something like quote unquote dirty until you get the team coming. But thank you guys so much for doing this today. I just want to make sure, so we have new Suprathel. It's put in the OR. We're using it for bigger partial thickness burns right now. There really aren't any drawbacks to using it. And when it's put in the OR, you're putting the interface and then the zero form and then the Curlex and then maybe some Coban, and then you keep that on for 3 to 5 days. Is that what you were saying?
Yep.
Okay, so like 3 to 5 days, and then when you take it down, do you put more on it, or like what do you do when you take it down?
It's really how it looks. I mean, we're trying to figure that out too. The company will tell you that if anything is kind of sloughed away, you can put more Suprathel back on. We've either rewrapped it, right, Anne, or used Silvadene even over some areas that kind of are declaring themselves as deeper. So I think it's just important to remember that burns evolve, they change. Parts of the burn might heal, other parts might get deeper over time. So we really just have to kind of, be flexible and kind of figure it out as we go.
But it depends, and we'll wait and see what it looks like kind of response. But it's true. It just depends on what it looks like once we take it down.
Okay. Well, thank you guys so much for coming and talking about this today. And I really look forward to our next one where we talk about all the things to do when a burn dressing gets soiled in patients. Thanks a lot.
That's a good one.